MSK Pathology, bone tumors. All right, so finally, for our last thing that you have to know is our bone tumors. And to be honest with you, I hated the bone tumors, but thankfully they're not that high yield. There's only two very, very high yield ones that you have to know. That's going to be osteosarcoma and then Ewing sarcoma. But because of your guys' feedback, I'm going to go kind of just quickly run through all the other bone tumors just so that you can have kind of a full understanding of what's going on, and just in case if you do get other questions on it. So they're separated via benign and malignant tumors. The benign tumors, the first thing I want you to take away from all of this is the location of the tumor. If you know the location of the tumor, it will help you kind of hone in on which one. It can give you a better chance of guessing which one is what, okay, that they're asking in a question stem. So there's three different locations in which a tumor can grow. It could be in the diaphysis, it could be in the metaphysis, or it could be in the epiphysis, okay? Now, the way that I remember the order is emergency medicine doctors. Okay, so emergency medicine doctors, EMD. So that's from like the top of the bone, epiphysis. Next is metaphysis, and then the actual long part of the bone is diaphysis. So emergency medicine doctors, EMDs. Now, let's start off with the epiphysis. The epiphysis is going to be just giant cell tumor. So if you see a tumor that's at the epiphysis, it's going to 100% of the time be your giant cell tumor. It's the only one present at the epiphysis. So boom, there you go, giant cell tumor. And what it will present with, like that's characteristic on X-ray, is a soap bubble appearance on X-ray. Okay, so if you see any type of bone cancer that's at the epiphysis, it's going to be giant cell tumor. And then if they say a soap bubble appearance on X-ray, then you know for sure it's giant cell tumor. Perfect, we're done with one of them. Next is going to be the metaphysis. At the metaphysis, you have osteosarcoma and you have osteochondroma. All right, so those are the two types that are at the metaphysis. Osteosarcoma is going to be the malignant tumor that is very, very high yield. So let's dive into it. So it's at the metaphysis, right? And what they want you to know is that it is, first off, peak incidence of primary tumor is in males less than 20. Okay, so that's going to be your population, but that's pretty much majority of our bone cancers. What they also want you to know is that it's usually with a prior radiation history. So prior radiation is a risk factor. All right. And it has its association with familial retinoblastoma. I don't know if you remember talking about it in neuro, but retinoblastoma has an association with osteosarcoma. Okay. So those are your associations: prior radiation and retinoblastoma. It's located once again at the metaphysis of long bones. Okay. And the characteristics is what really separates it from everything else. This is what you want to know. Remember, this is malignant, so it's scary. So the first thing you want to know is that you'll see a Codman triangle, okay, or sunburst pattern on X-ray. So take a look in your book or look it up. They will show you either a Codman triangle or sunburst pattern on X-ray. And that is indicative of osteosarcoma. That is what they will show you, okay? Now, what they want you to memorize is kind of just like this mnemonic, which is my favorite thing. So osteosarcoma, that's how I remember, osteosarcoma. So it's like shark. So we're talking about fishes, okay? Is Codman triangle, right? So cod is another fish that swims under the sun, so sunburst pattern. So osteosarcoma, Codman triangle, sunburst pattern at the metaphysis is very, very high yield. So that's your osteosarcoma. Your other metaphysis tumor is going to be osteochondroma. Once again, not too high yield. This is a benign tumor. And what you need to know, kind of main takeaway, is that it's capped with cartilage. So if you take a look at what that cap looks like, it like projects out from the growth plate and it has a cap. It's like a pointy thing pointing out from like near the growth plate. And there's like a cartilage cap on it. So that's all you need to know. It's very easy to point out on imaging. All right. Next, we have our diaphysis. We have our osteoid osteoma. We have Ewing sarcoma, myeloma, and fibrous dysplasia. Okay, so let's start off with our osteoid osteoma. Osteoid osteoma is just going to be essentially bone pain that's worse at night that is relieved by NSAIDs. Okay, relieved by NSAIDs. That's osteoid osteoma. It's usually going to be in the diaphysis. All right. Now, osteoblastoma is also a malignant tumor that's not found in the diaphysis. It's found in the vertebral bodies, but it's very similar to osteoid osteoma. That's why I'm bringing it up. But the pain is unresponsive to NSAIDs. Okay. Once again, remember, these are lower yield, so don't get too bogged down by this. Next, I'm going to talk about is Ewing sarcoma. Ewing sarcoma is the last one at the diaphysis that we really, really care about. Ewing sarcoma is usually going to present, usually in white patients, generally males, that's less than 15 years old. So it's not going to be that helpful because that's pretty much all the presenting people. Now, it's going to be in the diaphysis, as we already discussed, usually of long bones, especially in the femur. And what they want you to know is that you will see on histology anaplastic small blue cells of neuroectodermal origin. So take a look at what those small cells look like on histology, because that is the key thing they show you for Ewing sarcoma. They will show you those small blue cells, and you're going to have to know it's Ewing sarcoma, okay? Very, very high yield. You have to know that, all right? Now, another thing, it can met to the lung. It can have metastases to the lung. It's very common to met to the lung. Ewing sarcoma can metastasize to the lung, and it can show onion skin periosteal reaction, okay? So Ewing sarcoma can also show on histology onion skin periosteal reaction along with anaplastic small blue cells of neuroectodermal origin. Remember those two histological findings and you will be good for Ewing sarcoma. It's very high yield, and make sure you know what it looks like. And remember that it metastasizes to the lungs. What they do for testing is that they'll do T1122, translocation T1122 for testings of Ewing sarcoma. All right? So it's very hard sometimes to differentiate Ewing sarcoma from osteomyelitis. The way that you can differentiate them is one, via histology, right? Anaplastic small blue cells and onion skinning. Two, if blood cultures and tumor aspirations are sterile, then that's how we know it's Ewing sarcoma compared to osteomyelitis, because osteomyelitis will not have a sterile blood culture or aspiration of the bone. All right? So that's your two high yield things. Ewing sarcoma is diaphysis. Osteosarcoma is metaphysis. Ewing sarcoma is going to see anaplastic small blue cells. Make sure you know what that looks like. And onion skinning with T1122 translocation. Osteosarcoma is going to have Codman triangle with sunburst pattern. Make sure you know what that looks like as well. Okay. Now, overall, this is what I'm going to leave you with. To remember the ones that are in the diaphysis. Di means two, right? So diaphysis is going to be the ones with two words. So Ewing sarcoma is two words, and so it's at the diaphysis. Osteoid osteoma is two words, so it's at the diaphysis, okay? And then you have giant cell tumor, which is the only one at the epiphysis, so that leaves the metaphysis for osteosarcoma, all right, and osteochondroma, right? So that's kind of the end-all be-all for our primary bone tumors. The malignant ones are the most important ones, osteosarcoma, as well as Ewing's sarcoma, all right?